Systemic lupus erythematosus, or SLE, is a prototypical autoimmune disease. It's characterized by multi-system involvement affecting about 1 in 2,000 individuals, predominantly women of reproductive age, with a 9 to 1 AFAB to AMAB ratio. Lupus involves immune complex deposition that damages the skin, kidneys, heart, lungs, and the central nervous system. It manifests as a malar rash across the face, often, as well as arthritis, nephritis, and serositis. This slide here likely depicts clinical or laboratory findings in lupus, things like photosensitive rash, nephritis, or hematologic abnormalities. ANA testing is almost universally positive in lupus, but further testing for anti-dsDNA or anti-Smith antibodies provides stronger diagnostic specificity. These antibodies correlate with disease activity, particularly in lupus nephritis. Then when we look at our different patterns here, we can see this peripheral rim pattern. This suggests that antibodies are directed against double-stranded DNA. This pattern is most characteristic of systemic lupus erythematosus, but could also appear in other connective tissue diseases because these antibodies do correlate with disease activity. Repeating an anti-dsDNA testing can help monitor a lupus flare or even lupus remission. The homogeneous pattern indicates antibodies to DNA, histones, or deoxyribonucleoproteins. It's common in lupus and in drug-induced lupus caused by certain medications listed on this slide, one being like hydralazine, for instance. It can also appear in rheumatoid arthritis. Therefore, you want to always correlate a homogeneous pattern with medication history to distinguish the true autoimmune reaction from a drug reaction. Sjogren's syndrome is a chronic autoimmune condition primarily targeting the exocrine glands, leading to dryness of the eyes and mouth, affecting about 1% of the population and often coexisting with rheumatoid arthritis. Women or AMAB individuals are 9 times more often affected than our AMAB individuals, typically between the ages of 40 to 60. And because chronic lymphocytic infiltration, these patients do have an increased risk of developing lymphoma of up to, around the 40 times range, so pretty significant risk. With Sjogren's, beyond dryness, it can involve other organ systems like the skin, lungs, kidneys, and GI. Diagnosis can be confirmed via salivary gland biopsy, which will reveal a lymphocytic infiltration. The parotid gland biopsy is also particularly sensitive, and serologically, the presence of anti-Rho or SSA and anti-Law SSB antibodies supports diagnosis with about 60% and 30% positivity, respectively. Looking at some ANA patterns for Sjogren's, the speckled pattern is often seen with Sjogren's syndrome. It also can be seen with lupus. Specific antibodies like anti-SSA, Rho, and anti-SSB, Law, or anti-RNP can appear in multiple connective tissue diseases. So recognizing this kind of overlap is really important, as a positive SSA or SSB result does not necessarily mean that Sjogren's is the diagnosis, especially if clinical features are absent. Diagnostic criteria for Sjogren's includes chronic dry eyes or mouth lasting more than 3 months, objective evidence of reduced tear or saliva production, and either characteristic biopsy findings or positive antibodies, such as anti-Rho or anti-Law. The Schreiber test measures tear production, while salivary flow and imaging assess gland function. Diagnosis typically requires a combo of symptoms, objective tests, and serology. Scleroderma, or systemic sclerosis, is an autoimmune connective tissue disorder characterized by excessive collagen deposition, leading to skin thickening and organ fibrosis. It is more common in our AFAB individuals, with onset typically between 30 and 50 years of age. You can see symptoms like Raynaud's, skin tightening, and internal organ issues, specifically in the lungs, heart, and kidneys. Antibody testing can aid in distinguishing diffuse from more limited forms of the disease. With scleroderma, the diagnosis is based on both major clinical and serologic findings. Clinical criteria include sclerotic skin thickening that extends to the proximal metacarpophalangeal joints. Minor criteria include sclerodactyly, digital pitting scars, and bibasilar pulmonary fibrosis on X-ray. Meeting the major or two minor criteria supports the diagnosis. Early recognition is really important here because internal organ damage, specifically fibrosis in the pulmonary and renal organ systems, really drives morbidity and mortality for this condition. Oftentimes, patients will first present with Raynaud's phenomenon, followed by swelling and thickening of the fingers and hands. Skin will become shiny and tight, restricting movement. And over time, internal organs like the gut, lungs, heart, kidneys, and thyroids can be affected. Arthralgias and proximal muscle weakness are common, and because symptoms evolve gradually, serial monitoring and antibody testing help track disease progression. The nucleolar pattern for ANA is associated with antibodies directed against nucleolar components, which is most commonly seen in scleroderma, but can also be seen in lupus. The key antibody here is anti-SCL70, which targets topoisomerase 1. Its presence would correlate with diffuse cutaneous involvement, as well as interstitial lung disease. Recognizing the nucleolar pattern on immunofluorescence can help guide confirmatory antibody testing. Anti-centromere antibodies are highly specific for the CREST syndrome, which is a limited form of scleroderma. CREST means calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Up to 90% of CREST patients test positive for these antibodies. And in contrast, patients with diffuse scleroderma often have anti-SCL70 positivity. The pattern of ANA testing appears as discrete centromere dots under fluorescence microscopy. CREST represents a milder, more indolent subtype of scleroderma with, again, that primary distal skin thickening and limited visceral involvement. Despite a slower progression, these patients remain at risk for pulmonary hypertension, digital ischemia due to vascular change. Anti-centromere antibody testing can help confirm diagnosis, but ongoing monitoring is essential because organ involvement can develop over time. And on fluorescence microscopy, the centromere pattern appears as bright, discrete dots corresponding to centromeric regions of the chromosome. The pattern is diagnostic for CREST syndrome when combined with clinical features, and the visual pattern recognition reinforces how ANA testing not only identifies autoantibodies, but also visually categorizes autoimmune diseases subtypes based off of anti-antigen localization. When we come back, we're going to look at our polymyositis and dermatomyositis.